Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. My name is Martiza. I'm a medical student of Bengkulu University. In Honorable Dr. Wisma Yunita, MPD, and Missouri, today I'm going to presentation an article. The title is Cataract Surgery and Dry Eye Disease. The abstract have table of contents are aim to review published literature concerning cataract surgery and dry eye disease, or DED. Methods: a search was undertaken using the following databases, such PubMed, Web of Science, and each other. Results: publication identified included systematic reviews, meta-analysis, randomized controlled trials, cohort studies, case series, and laboratory-based studies. Published data highlighting the burden of DED both prior and following cataract surgery were reviewed, as well as studies highlighting the effects of cataract surgery on the ocular surface. Intraoperative measures to reduce deleterious effects on the ocular surface, and current evidence on the management options of postoperative DED. Conclusion: DED is common and can be exacerbated by cataract surgery. Ophthalmologists need to assess for pre-existing DED and instigate treatment before surgery. Be aware of reduced accuracy of measurements for surgical planning in the presence of DED. Limit intraoperative surgical factors damaging to the ocular surface, and consider management to reduce DED postoperatively. Introduction: The development of visually symptomatic cataract is common, although the technological breakthrough in cataract surgery over the past half-century have had a positive impact on the quality of life, or QOL, of millions of individuals around the world. There are potential complications, which in cataract surgery may be both sight and non-sight threatening. Such an example is dry eye disease, or DED, such that the detrimental effect of cataract surgery on the ocular surface can both directly cause and exacerbate pre-existing DED. This is important not only with reference to symptomatology and complications of DED itself, such as increased risk of infections, but also with regard to accuracy of preoperative assessments. The aim of this narrative review is to assess the intraoperative factors in cataract surgery which affect the ocular surface, particularly in relation to the development and exacerbation of pre-existing DED. The evidence surrounding the operative and intraoperative considerations to limit harmful effects on the ocular surface will be reviewed, as will potential post-operative management options in the treatment of DED following cataract surgery. Methods: a search was undertaken using the following databases, such PubMed, All Years, the Web of Science, and each other. Search terms include cataract surgery, phacoemulsification, and cataract extraction combined with dry eyes, and ocular surface. Public data highlighting the potential burden of dry eye disease DED, both prior to and following cataract surgery were reviewed, as well as studies highlighting the effect of cataract surgery on the ocular surface. Intraoperative measures to reduce deleterious effects on the ocular surface, and current evidence on the management options of the post-operative dry eye. Results: a total of 145 publications were identified as relevant to subject matter of DED and cataract surgery for this narrative review. Prevalence of cataract surgery-associated DED. The prevalence of DED after cataract surgery is unclear. It is important to note that persistent post-surgical discomfort, which occurs after many surgical events such as laser refractive surgery, dental implants, and genitourinary procedures, can manifest and overlap with DED after cataract surgery. Report, Reported postoperative discomfort in 34% 6 months post-surgery, with greater prevalence in women and those with autoimmune disorders, non-ocular chronic pain syndromes, and usage of antihistamine, anti-reflux, anti-insomnia, anxiolytic, and antidepressant medications. The background of DED. DED is a complex disease process, and this is highlighted by the lack of globally agreed definition. A multifactorial disease of the ocular surface characterized by a loss of homeostasis of the tear film and accompanied by ocular symptoms in which tear film instability and hyperosmolarity, ocular surface inflammation and damage, and neurosensory abnormalities play etiological roles. The pathophysiology of cataract surgery associated DED. These factors appear to include incisional corneal nerve injury and ocular surface damage from the toxic effects of components of eye drops, ocular surface drying or repeated irrigation, phototoxicity, and surgical trauma. Incisional corneal nerve damage. In laser keratorefractive surgery, the treatment of pre-existing DED, exclusion of patients with intractable DED, and routine use of post-operative lubricating drops are consistently undertaken to minimize DED due to corneal nerve damage induced during procedures such as laser in situ keratomyeliosis or LASIK, and photorefractive keratectomy (PRK), with patients being warned and consented by preoperatively of the occurrence of such problems. Ocular surface damage due to the toxic effects of eye drops. The use of eye drops during the after surgery may lead to potentially harmful effects on the ocular surface with injury to corneal epithelial and conjunctival epithelial and goblet cells. Repeated intraoperative ocular surface drying and irrigation. Such investigations intimate that intraoperative ocular surface drying and need for frequent irrigation during cataract surgery are important factors in the pathophysiology of cataract surgery-related DED. Phototoxicity. The phototoxic effects of the operating microscope light on the ocular surface have been demonstrated in both laboratory and clinical studies. The effect of microscopic light on rabbit eyes demonstrated damage to corneal and conjunctival epithelial cells, reduced aqueous tear production, and a reduction in goblet cell density. Femtosecond laser-assisted cataract surgery, or FLAC-S, and DED. It appears from these limited studies that FLACs may have slightly greater propensity to cause DED compared to PCS. This may be attributable to additional ocular surface trauma from the FLAC suction ring damaging limbal corneal, conjunctival epithelial cells, and conjunctival goblet cells. MGD and cataract surgery. MGD is common and can contribute to DED. A prospective case series by Han showed that following cataract surgery, there are increased lid margin abnormalities at 3 months. Lubricating eye drops. The use of lubricating eye drops, including gels or ointments at night, and punctal plugs are effective in treatment of both ADDE and EDE. Intraoperative management of DED. The cataract surgeon needs to be mindful of these factors when operating on patients, especially when a patient has any pre-existing DED. Postoperative management of DED. Optimization of standard treatment regimens. As part of standard care following cataract surgery, patients are given courses of topical steroid, nonsteroidal, anti-inflammatory, and antibiotic drops for about 1 month. They are useful and adjunct and the author's preferred choice for patients undergoing cataract surgery with pre-existing DED. Lubricating eye drops. There have been several studies looking at management of post-operative DED with lubricants eye drop following cataract surgery. It is clear, however, that significant additional research is required to optimize post-operative lubricant drop regimens with regard to both their preferred components and the durations or frequency of the administration regimen. Topical cyclosporin drops. Inflammation is a key component in pathophysiology of DED. Cyclosporin eye drops have been shown to be effective in the management of DED. Mucin secretagogues. Loss of conjunctival goblet cells contributes to the development of DED, and cataract surgery has been shown to cause goblet cells dropout. Goblet cells secrete mucins which have roles in maintaining ocular surface lubrication and in the removal of debris from the ocular surface. Other treatment interventions are anti-inflammatory agents, omega-3 supplementations, lactoferrin, tea tree oil lid scrub, and bandage contact lens. The conclusions is DED is a common condition and can be induced and aggravated by cataract surgery, with a considerable consequence on the QOL of patients. A significant number of patients may present to the cataract pre-assessment clinic with pre-existing DED, and due to the discordance between clinical signs and patient symptoms. Clinicians are faced with challenges in the effective diagnosis and management of these conditions. Preoperative assessment for pre-existing DED is essential to ensure that patients receive appropriate preoperative DED treatment prior to cataract surgery and to ensure that accurate measurements are obtained in terms of biometry and corneal topography or tomography for surgical planning. Cataract surgeons should be mindful of the detrimental intraoperative effect of cataract surgery on the ocular surface and take steps to limit this. Post-operative management of DED is crucial in ensuring that tear film homeostasis is preserved as much as possible and to avoid long-term adverse effects of the ocular surface. Considering the great regularity with which cataract surgery is undertaken, the associated high patient expectations, and high frequency of occurrence of DED, the finding of only 58 publications directly addressing DED in relation to cataract surgery is surprising and suggests that this problem might be overlooked by clinicians and requires much further investigation. There are my presentation. Thanks for watching. Wassalamualaikum warahmatullahi wabarakatuh.